Good afternoon, and thank you for joining the RLS Foundation's webinar titled Medications, Are My Doses Too High? My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Winkleman will answer as many questions as time allows at the conclusion of his presentation. The surge in the use of web-based programs during the COVID-19 health crisis has created a strain on the system. If you are experiencing technical difficulty, switch to the audio portion of the program as it uses less bandwidth. We thank you for attending and appreciate your patience and understanding during today's webinar presentation. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the member portal section of our website. If you are not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a Foundation member today at rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes only and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. John Winkleman. Dr. Winkleman is Chief of the Sleep Disorders Clinic Research Program, Department of Psychiatry at Mass Gen Hospital, a certified RLS Quality Care Center in Boston, Massachusetts. Dr. Winkleman received his PhD from Harvard in psychobiology and his MD from Harvard Medical School. He finished a residency in psychiatry and a fellowship in neurology, sleep disorders medicine at Mass Gen. He has served as chairman of several national organizations, including the Nosology Committee, the Movement Disorders section of the American Academy of Sleep Medicine, and the American Academy of Neurology Guideline Committee for the treatment of RLS. Since 2000, he has served on the RLS Foundation's Scientific and Medical Advisory Board. Dr. Winkleman's research interests include sleep-related movement disorders, insomnia, and parasomnias. He is a leading expert in the field of RLS and has published several textbooks and authored over 100 articles in the field of sleep medicine. Dr. Winkleman, we thank you for sharing your time and expertise with us and invite you to begin your presentation.
Thank you, Carla. I hope if there are technical problems, Carla will hop on and let me know. I always worry that I'm talking and no one can hear me, and I'm going to assume you can. I want to thank the RLS Foundation for doing these webinars. They're a really important source of information for patients with RLS. Unfortunately, those of us in medicine were not trained about restless leg syndrome, particularly those who maybe are a little bit older. And so this serves as a way to educate patients so that you can educate your providers. Let's see if I can get this to move forward. There we go. Here's a number of potential conflicts of interest, which you should keep in mind when listening to the content of today's talk. Well, I'm told that these are the scales of justice. But in fact, this was the best I could get from the internet in terms of weighing risks and benefits of medications. But I'm hoping you get the idea that this is what we learn to do in medicine from the beginning. Hopefully medications that, or any intervention that you're using in medicine has a benefit, that's why you're doing it. But all interventions also have risks and have short and long-term side effects. And you're always balancing them in the context of what you know about the individual person who you are helping. In general, the benefits for medications in RLS are that they're going to improve RLS symptoms, they're going to improve sleep, and there is the potential that over the long term, they may improve or reduce the risk of cardiovascular disease, for which there is some evidence that RLS increases people's risk of cardiovascular disease, and it's possible that medication treatments reduce that risk. On the other side of this balance, you'll see these side effects. There's immediate side effects, and then there are longer term side effects. In particular, the longer term ones that we're going to focus on today are the risk of augmentation or a worsening of RLS with dopamine agonists, DAs, and the risk of misuse or abuse with opioids. So let's keep moving. When we talk about medication dosages, it's really important to recognize that there are very specific issues that relate to RLS that are really not present for almost all medical disorders. RLS is pretty unique, if you can say pretty unique, in that it is time of day and activity dependent. How severe it is will depend on the time of day and whether you're moving around. Therefore, not only how much medication you take, but when you take the medicine and how physically active you are around the time that you're taking the medication will determine the extent of the symptomatic relief and the best times to take the medications. So like for high blood pressure, many of the medications you take once a day, and that's it. For diabetes, once a day. Doesn't make sense for restless legs because many people don't have symptoms in the morning or even in the afternoon, and therefore taking medications in the morning or the afternoon is really wasted medication. So we target RLS medications based upon when symptoms are present and how active people are. If they're people who can't move around much, then they're going to have more symptoms, and we need to address that time of day. If you can address your symptoms by moving around, getting up and taking a walk, then why waste medications at that time? So in general, for patients and doctors treating restless leg syndrome, I think about it a little bit like this. This is a picture I took 2 years ago of a surfer at a beach on Maui called Jaws. And we're always trying to get the maximum benefit, go as far as we can on that surfboard without having the side effects crash down on top of us and knock us off. Maybe it's a little bit of a reach and a metaphor, but I like this picture, so I wanted to show it. So let's talk about medications for restless legs. 4 classes of treatment are ones that are effective for RLS, really. These are the 4 that have proven efficacy. They're dopamine agonists, alpha-2 delta calcium channel ligands that we'll talk about in a bit. That's gabapentin, pregabalin, gabapentin emicarbol, iron, and opioids. And we're going to talk about 1, 2, and 4 there. Dopamine agonists, the alpha-2 deltas, and the opioids in terms of the balance between benefits and side effects and risks. So dopamine agonists, as many of you are aware, have been first-line treatment for RLS for more than 30 years. These were the first medicines that were approved by the FDA for the treatment of RLS. They constitute 3 out of 4 of the FDA-approved treatments, and they're wonderful medications in the short term. In the short term, this is like putting butter on a hot pan. It just melts the symptoms away for most people. Unfortunately, and we'll see some data on this later, over the long term, they make RLS worse. And I'm not going to belabor this because you've probably heard talks on this, but I'm wondering if people can see. Carla, could you say, can people see my pointer here? I don't know whether people can or can't, but I'm going to use it anyway. So RLS gets worse because augmentation starts. So what most doctors usually do is they increase the dopamine agonist dose, which then over time makes the RLS worse due to worsening augmentation, and around and around and around we go. And I have used the metaphor that this is like trying to put out fire with gasoline. Really is not going to work. Here are the 3 FDA approved dopaminergic drugs for restless legs: ropinirole, Requip, pramipexole, Mirapex, and rotigotine, Nupro patch. And here you see the upper limit of what the FDA has said the maximum dose should be. Okay, thank you. Somebody just texted me and said, we can see your pointer. So 4 milligrams is the highest dose that the FDA says should be used of Requip, 0.5 milligrams of Mirapex, and 3 milligrams of Nupro. So very briefly, let's just demonstrate that pramipexole Mirapex works. Here's a study that I published now 15 years ago. It was the pivotal study for the FDA approval of Mirapex. At the time, I thought this problem was all solved. RLS would disappear because we'd be using these medications and they were great. And you can see here that about 50% of people were responders to placebo, but somewhere between 70 and 75% of people were responders to pramipexole, depending upon the dose. But now, so that was definitely an improvement there, benefit for RLS symptoms. Now let's look at side effects. What are the most common side effects with pramipexole? You see each one of these columns are different doses, 0.25, 0.5, and 0.75 milligrams. And you can see that nausea was present anywhere from 10 to 25% of people, depending upon the dose. Headache present in about 20%. Some people had insomnia, other people had sleepiness. And so these medicines do not only have the longer term concerns like augmentation, but short-term side effects, as we see here. But as I'm sure you're aware, the longer-term issue is this augmentation, a worsening of RLS over time with use of these medicines. And in particular, the worsening occurs as an earlier onset of symptoms. Before people were taking medications for RLS, let's say their symptoms started at 10, and then they took the medicine at 9 p.m. and they were great for a while, and people were bringing me chocolates and flowers, and they thought I was wonderful, and I thought that I was wonderful. Unfortunately, that became clear that I wasn't so wonderful and that the medicines weren't so wonderful, because within a couple of years they'd come back and they'd say, you know, doc, I have to take the medicines now at 6 p.m. because my RLS symptoms are starting at 7. And I'd say, well, why don't you continue taking them at 6, and I'll give you a little extra to take before bed because it's not lasting as long. And then a year or two later, they'd come back, doc, it's now starting at 2 o'clock in the afternoon. So this is augmentation, earlier appearance, so spread time-wise and spread body-wise from the legs up to the arms. And here you see the number of people who don't have augmentation over time. And this is from a Johns Hopkins sample from about 10 years ago. And you can see that at around 10 years, there was only 30% of people didn't have augmentation. Roughly 75% of people by that time did have augmentation. The risk factors for augmentation is dose. That's the biggest known risk factor other than iron deficiency. Those two are really the major risk factors for worsening of RLS due to these medications. And here's a study which really, I think, established that. I'm very proud of this study that Richard Allen and Diego Garcia Borrero and I published and 7 years ago in the New England Journal of Medicine. And here you see the dose-related effects on augmentation. 0 pramipexole, low dose pramipexole at a year had 5% augmentation, and higher dose pramipexole, and this is not even high dose, higher dose pramipexole had about 8% augmentation at 1 year. This is just at 1 year. So in trying to understand how many people there are in the US who have augmentation, you can't go out and ask 1 million people in the United States who have RLS, interview them and figure out if they had augmentation. So what I tried to do recently is get some insight about this by looking at the doses of the dopamine drugs that they're taking. And so this paper, this is a preprint here. It's just coming out in the journal Sleep in the next month or two, really. And what we did is we looked at a database that tracks prescriptions in the United States. And we looked at 150 million de-identified patients and corresponded to over 1 million different prescribers. And then we extrapolated to all the people in the United States. This is from 2017 to 2018. We looked for those people who had a diagnosis of restless leg syndrome, no Parkinson's disease. We didn't want to confuse things. And we looked to see whether they were on dopamine agonists or on other medicines for restless legs. And this is the most important part here, as the plane flies over my house. The most important thing is we divided the dopamine agonist doses into low, or low to moderate, which were FDA approved, high, which were 100% to 150% of the FDA maximum, or very high, which is 150% of the FDA maximum. So for pramipexole, very high was above 1.25 milligrams. For ropinirole, it was above 6 milligrams. For rotigotine, above 6 milligrams. And we were trying to get some insight, figuring that people on high and very high doses didn't start there, but in fact worked their way up there, probably due to augmentation. And we ended up looking at about 400,000 people in the United States taking dopaminergic drugs for restless leg syndrome. And here's the bottom line. Nearly 20% of all RLS patients in the United States taking dopamine agonists were on high or very high doses. This is about 75,000 people. And here you see 81% people on any dopaminergic medication were taking FDA approved doses, but 8.6% were taking high doses, and over 10% were taking very high doses. And anybody, I think, who treats RLS patients would recognize that these are very high or high doses. What was interesting is that 2/3 of the people on these high or very high doses were taking pramipexole. Pramipexole is really the medication that gets to these high doses. 1/3 of all high and 2/3 of all high and very high dopaminergic prescriptions were for pramipexole, and 1/3 of all pramipexole doses were high or very high. So unfortunately, pramipexole is the main issue here with high and very high doses. Not to say that ropinirole had about 10%, 8.8% were high or very high. So this is clearly an issue, and it's been an issue that's been recognized for quite a while. In 2008, at the RLS scientific meeting at NIH, this is a slide that I presented then 13 years ago, and I said not only are patients addicted to these dopaminergic drugs, but clinicians themselves are addicted. because the response, the benefit is predictable and rapid. And we've got a problem. And this is where a lot of high doses end up for individuals. And here's a great Will Rogers quote that I like. If you find yourself in a hole, the first thing to do is stop digging. And I would convey this to you. If you find that you are on a dopaminergic drug at or really above the FDA recommended maximum, so above 0.75 milligrams of pramipexole, above 4 milligrams of ropinirole or rotigotine, stop. Talk to your doctor. Something bad is going on that's only probably going to get worse, and that's augmentation. The bad news is you can't just stop these dopaminergic drugs. Because as many of you know, if you take even one night off, restless legs comes back like a bear. And this is this RLS rebound that people have on withdrawal. And here's a study that demonstrates this. This was not the point of this study, but it did demonstrate this. These are people who were successfully treated with pramipexole, and here were switched to placebo. And you can see that 90% of them continued to have a good response over about 3 months. However, the people who were switched, these are people who were on pramipexole and continued on pramipexole. These are people who were switched from an effective dose of pramipexole to placebo. And you can see that by a week, about 85% of them had relapsed, and the restless legs had gotten much worse. In fact, worse than it had been even before they started the medication. So we'll return to some of these themes later, but now let's talk about calcium channel, alpha-2 delta ligands, gabapentin, Neurontin, gabapentin N-acarbonyl, Horizont, and pregabalin Lyrica. And these are the usual doses that are used. The only one that's FDA approved is gabapentin N-acarbonyl, and here's the approved dosages for RLS. And here's a study that study that I referred to, the New England Journal of Medicine study. You can see that it works. There's benefit of pregabalin. 71% of people were responders, whereas with placebo is less than 50%. This medicine at this dose is effective, but this medicine also can have side effects. And if you look, over a quarter of people taking 300 milligrams of pregabalin stopped their pregabalin over the course of a year due to side effects. The most common side effects were dizziness, sleepiness, fatigue, headache, weight gain, et cetera, et cetera. The important thing to remember about the alpha-2 deltas, there are many important things. One important thing to remember is that gabapentin has what's called non-linear pharmacokinetics. It is poorly absorbed once you get above about 400 milligrams at a single dose. So here you can see somebody taking 1,400 milligrams all at once, and here's their blood level, let's say about 60, and they had half that blood level at 400 milligrams. So really, this should have been at 800 milligrams. They should have been at 60. But because the gut can only absorb so much gabapentin at one time, as you increase the dose, you get less and less and less absorption. And therefore, even high doses of gabapentin taken at a single time do not produce high blood levels. If you want to increase blood levels, you have to split the dose. Take some at 6 p.m. and again at 9 p.m. That way, by 9 p.m., all of the medication that was given at 6 p.m. has been absorbed, and the receptors are ready for action again, ready to absorb more. The thing to remember about gabapentin enicarbal is that how much of the dose you absorb here is dependent upon whether you are fasted or whether you've taken it with a meal. If you take Horizon, gabapentin enicarbal with a meal, you're going to get about double the absorption you would if you took it when you're fasted. So an important thing to remember about that medication. Okay, let's think about opioids. A lot to talk about here. I'm going to try to do it in 7 or 8 minutes. Commonly used opioids for restless leg syndrome. What is a high dose of an opioid? We can't depend on FDA guidelines because no opioids are approved for RLS. So we really have to base this on our judgment from reading the literature and from individual people's responses. So opioids that I misspelled here not only have acute side effects, immediate side effects, particularly constipation and sleepiness, but they have longer term side effects and risks that we have to worry about. Overdose, abuse and misuse, EKG abnormalities with methadone, euphoria, withdrawal upon abrupt discontinuation, and respiratory suppression. So we really need to be careful with these, this balance when we're using opioids. The thing about opioids is each medication has a different potency, and therefore to figure out how much of a certain drug you are giving, we translate that medication into an equivalent for morphine milligram equivalents, or MME. I'll show you a little bit more about this in a second. But the important thing here to recognize is that once you get above a certain level of MME, the risk of overdose increases substantially. This is why we keep doses low for RLS. The good news is that low doses of opioids work for RLS. So I'm not going to go into details, but here's a graphic that shows that oxycodone works for RLS. And here we see the immediate side effects with this oxycodone. Fatigue in about 1/3 of people, constipation in 20% of people, nausea in about 20% of people. Those are really the big ones. So in response to all of the overdoses with opioids over the past 10 to 15 years, many doctors aren't prescribing these medicines at all. I mean, at all. And this is good in one respect because it has reduced overdose rates. However, at least from prescribed opioids, however, there are many people in pain or with RLS who are not getting treatment that they would benefit from and that would be safe for them. I do want to note that the RLS Foundation has been involved in advocacy efforts at the federal level to raise awareness that opioids are an effective and can be safe treatment for RLS. And to learn more about opioids and RLS, I initiated this national RLS opioid registry a few years ago, and we enrolled 500 participants. We were hoping just to get 200, but the interest was so overwhelming that we just kept enrolling and we went up to 500. And so we are characterizing people with RLS across the United States who are taking opioids. The vast majority of people have low risk of abuse of the medications using this opioid risk tool. And therefore that is gratifying and reassuring that you can use medications if you are careful and evaluate people for their misuse and abuse risk beforehand. Which opioids are people taking? The vast majority of people are taking methadone, almost 50%, and then another 30% are taking oxycodone short or long-acting. And you can see in terms of side effects, about 50% of people have constipation, about a quarter have drowsiness or fatigue, 20% with itching, etc. Sweating is a problem. It's a big problem for some people. So balancing how much medication to give, how much do you need to treat the RLS versus how do you avoid these side effects, that wave from crashing on you, is really the issue. And here you can see the MME distribution of the 500 people who are in the opioid registry. 81% of people are on morphine milligram equivalent less than 50, and that's less than 12.5 milligrams of methadone, less than 35 milligrams daily of oxycodone. And 50 is kind of considered a somewhat of a cutoff for safety. Another cutoff might be 80 or 100 MME. And I'm not going to go into this in great detail, but we identified those people who are using higher doses. And generally, the strongest predictor is people who are using an opioid for non-RLS pain condition, low back pain, arthritis. That triples your risk of being on a high dose of an opioid. What doubles your risk is if you had RLS that started before the age of 20. Methadone itself, you were using methadone, that increased the risk of a higher dose. Similarly, if you had a higher opioid risk for abuse score, and similarly if you had painful RLS. We've also followed people out now for 2 years. We have, in fact, many of the people are out to 3 years, but we haven't analyzed that data. The majority of people still are at the original dose that they were in when they started this study. They'd already been on opioids for a median of 2 years when they entered the study. And you can see here the majority of people either stayed at the same dose or had a very small increase over the 2 years they were in the trial. And who's increasing the doses? Again, it's people who are using opioids for RLS as well as another pain condition. Also people with depression, men, people who'd stopped gabapentin or dopamine agonists since they'd entered the registry and then probably needed to increase their dopamine agonist. And finally, I think that this is one of my last slides. Many people that I talk to are very anxious about the stigma that opioids have among healthcare professionals. And about a quarter of people said that they had been discriminated against because of a healthcare professional, because they were on an opioid. Almost 100% of people said that they were worried about opioid regulations and that they would interfere with their access to this medication. And this is where the foundation and educational efforts come in. We really need to reach more doctors to give information about opioids for RLS that is balanced, that discusses the benefits, but also discusses the risks. I do want to mention that doses of medications cannot be used in isolation, because many people are taking not only an opioid, but also gabapentin or pregabalin, and maybe even some clonazepam or lorazepam or alprazolam, a benzodiazepine. And the combinations of these medications increases the risks. It may increase the benefits, but it also increases the risks of sedation, respiratory suppression, risk of abuse, and potentially in producing some euphoria, which may drive misuse of these medications. So I want to conclude here so we can get to questions. What's the right dose? There really is no right dose. There's a right dose for you based upon your medical history and your response to the medication. And that can only be determined by you and your healthcare professional in collaboration. That right dose maximizes benefits and minimizes side effects and risks of longer-term issues. Given that RLS is time of day and activity dependent, we want to take the medication during the appropriate time of day and stay active at times when there are minimal symptoms present that you could take medication for, but maybe you could just get up and walk around and maybe symptoms would be at least temporarily relieved. Let's target the medication and that dose to the right time of day. Dopaminergic agonists have acute and long-term risks. Alpha-2 deltas, as we have seen, like pregabalin, gabapentin, have acute risks which may interfere with people's ability to take the medication. 25% of people stopped 300 milligrams of pregabalin by 1 year because of side effects. And opioids have both immediate, like sleepiness, constipation, itching, nausea, immediate side effects, and longer-term risks like abuse and overdose. And you and your doctor will work together, I hope, to try to maximize the benefits and minimize the side effects and risks. And I hope that in the next 5 to 10 years, we will have additional treatments which can enhance the benefits and minimize side effects and risks. And on that note, I'm going to stop and give the floor back to Carla.
Well, thank you, Dr. Winkelman. Always informative, but I'd also like to thank you for all of your work on the Hill with the foundation. When we go back and they ask, how is Dr. Winkelman, we know that you've made an impression on that legislator's office. So this is something that we're constantly working on every day here at the foundation. So do know that your support makes it possible. All right, we'll go ahead and start with the questions. First one, 2 milligrams of clonazepam is the only thing that works for me at 65. I know they don't want elderly individuals on benzos. What can I do at 85?
Well, it's again, I cannot give individual advice here. I know nothing about you other than you're taking 2 milligrams of clonazepam and that you're 65 and that you hope to be around at 85. So I don't know whether this 2 milligrams has always been the effective dose or whether you've had to crank it up over time. Even just being 65, going from 45 to 65 has increased your dose because your liver is less good at breaking down the clonazepam than it was 5 years ago or 10 years ago. And I don't really know whether you're having any side effects from the clonazepam. And clonazepam, these benzodiazepines, do have side effects. In particular, they impair coordination and they impair cognition. So people can fall, people can be unsteady and then fall, particularly in the middle of the night when it's you're a little bit out of it because you're sleepy and you're walking into the bathroom and you trip on your shoes that you left in the way, or you find that you're having more difficulty with word finding. It's not clear to me that when you say it's the only thing, I don't know what else you have tried. So there are a lot of options, as we've seen. Benzodiazepines are not one of the standard medications for RLS, and I think that I would discuss with your doctor trying to find a more standard medication, one of the 3 or 4 that I mentioned, to see whether that could reduce the dose of the clonazepam now, not stop it, but reduce it so that you can continue to benefit and not have side effects in 20 years.
Are iron infusions a good alternative to medication?
Iron infusions have been shown in a few studies to be an efficacious treatment for restless leg syndrome. We just published guidelines about 2 years ago, and we recommended IV iron for those individuals who have a ferritin level less than 100. Above 100, it was much less clear whether it was effective or not. It's not clear that it's not effective. It's just below 100 we felt that the benefit was clear. Now the only thing to note is that ferritin levels can be falsely elevated. They may not always be a good indication of iron status, and for that reason I always get not only ferritin, but I also get 2 other blood tests, and those are iron and TIBC. And if you divide iron by TIBC, you get what's called transferrin saturation, and I try to keep that above 20%. So that's the amount of iron that is bound to the its carrier protein.
Can an RLS patient develop augmentation from a short-acting opiate?
Interesting question. We generally don't call it augmentation. I would call it rebound, but I think that in many respects, the process is similar. For this reason, I generally don't use short-acting opioids because I find that over time, people may start to have symptoms earlier and earlier. And so let's say you're taking oxycodone, which is a short-acting opioid, or hydrocodone, also a short-acting opioid, codeine, short-acting opioid. You take it before bed and it works great for the first 6 months or something to falling asleep and maybe helping you sleep. But I've seen people who then start developing evening symptoms, and whether this is called augmentation or rebound isn't clear, but in general, I try to avoid short-acting opioids or ultra short-acting opioids like the ones I just mentioned.
Do you prescribe dopamine agonists for pediatric patients? If not, what is your preferred regimen?
I'm sorry, I won't be able to handle this question because I don't see pediatric patients. I just see adults. Adults are hard enough for me, and kids are, God, as everybody knows, they're so much harder. And so I think I would have to refer you to a lecture on pediatric RLS, and hopefully the foundation will be having a webinar on that sometime soon.
Hopefully next spring or summer. That's your teaser.
Excellent work. Carla, always one step ahead.
Does having a glass of wine or cocktail tend to interfere with medication? I take Requip 4 times a day.
My guess is that if you take Requip 4 times a day, you have augmentation. And augmentation is only going to get worse. So just to look into the future, I think this is something first that you should probably talk to your doctor about, because you probably didn't start taking it 4 times a day. That wasn't your question, though. Your question's about alcohol. I find that about half of the patients that I see say that alcohol reliably worsens their RLS. Their RLS is under good control, except on the nights when they have a beer or a glass of wine, and in those contexts, their RLS is bad. Now, am I telling you not to drink? No, I'm not telling you not to drink. I'm just saying that if you have a glass of wine, you need to recognize that on that night, your RLS might be worse, and you need to make the decision. The benefit here, it's the benefit of the wine for your life versus the risk or side effect of worsened RLS.
Does Tylenol inhibit dopamine production?
Not as far as I know.
How do we garner support for the use of opioids to treat moderately severe to severe RLS in the face of current restrictions?
That's a good question. We educate providers as much as we can, number one. And number two, we come up with data that is scientific and can be convincing. That's we can go to the Capitol as much as we want and talk to legislators there as we have done in the past. But what really is convincing to the scientifically oriented legislators is information. So we try to give them good information. And right now, unfortunately, there isn't enough good information, which is why I started the National Opioid RLS Registry. We need better information. We do have some long-term studies, but they were small, and they were generally from one center. I wanted to get people from all over the US at a number of centers, not just with RLS specialists, but with a variety of doctors treating them, and follow people for as long as I could until either they died or I died, which is my intention to continue with this registry. And I think that kind of data will be valuable. I wish I had done this sooner with the dopaminergic medicines. I was really gung-ho about them, and because the data looked amazing, but they were short-term studies. And it only became clear later on that these medicines were a problem. And it's kind of like fooled me once. I don't know how the saying goes actually, but I was fooled once, and I really don't want to be fooled again. And so I'm collecting this data to try to establish what the risks are of opioids for RLS. So far, I've been reassured by the data.
Well, true story, folks, is that when we're in DC, when Dr. Winkleman's there talking, when we talk about the opioid registry, pens come out and they start writing. They want to know what's going on in the registry, what we're finding, as well as other data. So having that RLS expert in the room is a game changer when we're talking about it, when we're talking with people at SAMHSA and other organizations where they're worried about opioid use disorder. Those are lively debates that go on behind the scenes. So know that you're getting, when you support the foundation, we're doing a lot of bang for your buck. Next question, how do you know if your current medication is not working and it's time for a change?
How bad's your RLS? It's really what it depends on. When you say not working, there's you're having RLS in the evening when when you get into bed, your legs are bothering you. They're waking you up in the middle of the night, or you have trouble falling back asleep. I've got restless dog syndrome here. And another way you might know that your medicine's not working is that it is appearing at times and places in your body where it didn't before. This is the augmentation. It didn't used to appear in the afternoon, and now it is. It didn't used to appear in your arms, and now it does. You didn't usually wake up with RLS symptoms at 4 or 5 o'clock in the morning because the medicine used to work all night. And now you are waking up at 4 or 5, so that the duration of benefit is reduced. So each of these symptoms are part of augmentation. And but in general, even with the other medications, if RLS symptoms are returning back to how they were before, I would say your medicine's losing its benefit.
In cases of severe RLS, when one is sleep deprived, can Ambien, Tramadol, and melatonin be taken at the same time?
They can be, but they should only be taken at the same time if your doctor approves it. The combination of the benzodiazepines, which Ambien is kind of like a benzodiazepine, with opioids can be dangerous in terms of respiratory suppression and in terms of instability or confusion in the middle of the night. So sleep deprivation definitely worsens RLS, but if it's RLS that's producing the sleep deprivation, Ambien is not the right response. The right response is to treat the RLS. Always with insomnia, go to the source, treat the source, because the sleeplessness may just be a symptom of something else, RLS, or pain, or depression, or a noisy environment. Try to treat the source, not the symptom.
What is the harm of having a dose that is too high if it's working? I'm assuming this is a dopamine agonist.
No, it could be for anything.
Okay.
It could be for any of the three classes of medicine.
Okay.
It's risks and benefits. And when you say too high, I'm not sure what you mean. You need to assess, and you and your healthcare provider need to assess whether the side effects from the medication and the risks of that dose are outweighed by the benefit or outweigh the benefit. And this is this balance that they are always going to be doing. Is the benefit outweigh the risk and the side effects? And so when you said too high, maybe as Carla said, it's above the recommended maximum for a dopamine agonist. The problem is that is increasing your risk of augmentation. And so it's working now, but what's going to happen in a year or 2 years? Your symptoms may start earlier, the medicine may poop out overnight, and then what are you going to do? Are you going to just increase the dose? As I said, if you find yourself in a hole, stop digging. And the hole is, I would say, the FDA maximum dose for dopamine agonists. For opioids, I can tell you just in terms of my practice, I do not prescribe more than 20 milligrams of methadone, do not prescribe more than 30 to 40 milligrams of oxycodone. I don't prescribe more than 100 milligrams of tramadol. That's where I set my threshold. Now, different doctors may have different thresholds, but that's what I'm comfortable with in terms of risks and benefits.
What is the simplest? Oh, I'm sorry.
Go ahead.
Next question was, what is the simplest but most direct way to approach my healthcare provider about the possibility of medicine change?
Medicine change, I would, I don't know if you mean to an opioid, but I would probably bring them some literature from the RLS Foundation, the medical bulletin, for instance, which we've just finished revising, and that'll be coming out soon. Bring them that information. Say to them, look, I'm not somebody who likes to take medication. In fact, I hate taking medication. I've always tried to avoid it. Hopefully that I wouldn't say that if it's not true to them, but this is really ruining my life and I need to do something about it. And if you wouldn't mind reviewing this, I think we could, next time we meet, discuss what the options are. And if you're not comfortable doing that, can you refer me to somebody who you think might be?
When experiencing augmentation and swapping from one medication to another, is it safe to do an immediate swap?
It's safe, but in my experience is rarely successful because stopping a dopamine agonist cold turkey is terrible. People have terrible rebound of RLS, and that can last certainly a week. And so I don't recommend it because it just usually ends up in failure. What I do is I add the medication that I'm going to substitute for the dopamine agonist to the dopamine agonist. So for a little while, you're taking 2 medications, and you want to then control the symptoms using that second medication. Then once you've gotten to a dose that controls RLS symptoms with the combination, then I start chipping away, and I mean slowly. In people on higher doses of dopamine agonists, this generally takes 6 months to get them off the dopamine agonist, sometimes longer. And if you try to do it faster, it just often ends up in tears and lack of success. So add the second medicine, then very, very gradually taper down, expecting to have an increase in RLS symptoms each time you drop down for at least a few days. I would drop down by 10% every month or so. Let's say every 2 to 4 weeks, depending upon where you're starting. Do it slow. That will lead to success.
When should a patient consider opioids for treatment of RLS?
When everything else has failed. They're really I use them for refractory, meaning treatment resistant medications, either because the medications didn't work, or because people developed augmentation, or because people had significant side effects to the medications that didn't allow the medications to be continued. But opioids are really last on my list after the alpha 2 deltas, which are number 1, iron always to be added if iron is low, and dopamine agonists if those 2 don't work. And then if none of the 3 of those work, then or are not tolerated or have developed augmentation, then I will use an opioid.
Okay, so last question is, tell us what RLS research you're working on these days.
Oh, that's very sweet of you to ask. I'm doing a number of studies. In addition to the registry, which I've described, I have a National Institute of Drug Abuse funded study to look at people who are withdrawing from opioids. And as some of my previous research has shown, people who are in detox from opioids, 50% of them have RLS. And if you talk to them, they'll say this is one of the worst parts of opioid withdrawal. It makes sense. Opioids help RLS. You stop opioids and you're going to get RLS. And so we are doing a double-blind, placebo-controlled trial of pramipexole, short-term. Here we're talking about 10 days versus placebo for 10 days in people in a detox who have RLS. And we're going to follow what happens with their RLS, what happens with their sleep, and importantly, are they able to stay in treatment longer? Or are they going to leave because their withdrawal symptoms, including RLS, are too bad and they want to leave. So that's one study. I'm also doing another study in people with restless leg syndrome that is controlled, but they continue to have insomnia. And I'm actually trying to recruit patients for this study. Your restless legs has to be pretty well controlled, but you still can't sleep, which happens to many people for a variety of reasons, mostly because I think they weren't sleeping for so many years, they just got used to having insomnia. So any of you out there who have well-controlled RLS and continue to have problems with sleep, insomnia, please reach out to me because you may be appropriate for this research study.
Right, and I think that's one that we just posted on the website.
I hope so.
Yeah, because we were talking to a new assistant about that, but
Yes.
that's a common call that we have here is insomnia, and also augmentation is the #1 call that we get at the foundation.
Well, this is a study with a hypnotic agent, a medication that treats insomnia, and we're trying to establish whether it is effective in this group of people who have treated RLS but continue to have insomnia. It's a marketed medication called Suvorexant or Belsomra, and we're trying to see if it's appropriate for people with well-controlled RLS and persistent insomnia.
All right, well, I wanted to thank everyone for joining us today. And thank you again, Dr. Winkelman. If you'd like to see where our next or register for our next webinar, go ahead to our website and go to the Get Involved tab, and then go to the Education and Events tab, and there's a pull down there, and it'll tell you where to register for the webinars. But have a great day, everyone, and thanks for joining us.
Thank you.
Thank you.
Sleep well.